All right, on to a new chapter, chapter 26, gastrointestinal disorders. It's a rather lengthy chapter, so I'm going to break it up into at least two different lectures. So we'll start with this first part on the gastrointestinal disorders. All right, abdominal pain is usually the first sign of some sort of gastrointestinal disorder, and it may be the only sign. Approximately 7% of the patients with abdominal pain have life-threatening conditions, or what we call either an acute abdomen or an abdominal catastrophe. Older adults and those who are immunocompromised are at increased risk of morbidity and mortality. Older adults, often because of their pain tolerances, they may have a serious abdominal problem like a necrotic bowel or something like that, that in you or I would cause significant abdominal pain, but because of their decreased pain tolerances, their condition can get extreme before it's actually noticed. And those, of course, who are immunocompromised are at greater risk of infectious processes of the abdomen. The GI tract include all structures in eating and processing food, to include the tongue, the mouth, the esophagus, and stomach, and all the intestines. It also includes, certainly the ancillary structures of the gastrointestinal system that aid in digestion of food, to include the pancreas, the gallbladder, that sort of stuff. So the structures of the GI tract help break food down, help absorb nutrients from the food that we eat, and help us eliminate waste. As we had mentioned, the GI tract starts with the mouth, the tongue, the salivary glands to moisten the food that you eat so that you can swallow it easier, your esophagus, your stomach, your spleen, your liver, and your pancreas are all part of the GI system as well, and then your small intestine and your large intestine, and we'll get into greater detail with those. The esophagus starts from the pharynx, the back of your throat, runs distally through your chest cavity, passes through your diaphragm, and terminates at the stomach. It's a hollow muscular organ that usually is collapsed unless you have water or food in it. It contracts as swallowed food moves downward from the mouth towards the stomach. This is known as peristalsis. It lies posterior to the trachea, and it is compressible, so most of the time it's flat. I liken the esophagus to sausage casing. When it's not full of something, it pretty much is compressed. It begins to the right of the aorta and passes anterior to the aorta as it transverses inferiorly. Now, the stomach lies inferior to the diaphragm in the left upper quadrant. It's partially covered by the left lobe of the liver. It's protected by the rib cage. Food, we know, passes from the stomach, enters into the duodenum through the pyloric sphincter. Food that we swallow ends up in the stomach, where the initial breakdown of the food occurs. The gastric juice in your stomach, very acidic, helps break that food down so that absorption can begin. The duodenum is the first part of the small intestine. Nutrients are absorbed as food moves through the small intestine by peristalsis, and the food progresses from the duodenum through the jejunum and then into the ileum, the three parts of the small intestine. Something to keep in mind is the ligament of Treitz. The ligament of Treitz is located at the junction of the duodenum and the jejunum. It attaches the diaphragm to the small intestine and allows for movement of contents in the small intestine as well. The appendix is a small appendage that arises from the initial part of the colon, and although it serves no purpose today other than becoming infected and inflamed and rupturing, when the appendix ruptures, because of the toxins that are released into the abdomen, it causes a peritonitis or an acute abdomen. The large intestine is where your water is absorbed. That's where bacteria break down and ingested food into nutrients occurs. You've got the ascending colon, the transverse large intestine, and the descending large intestine. The small intestine is quite a long structure, somewhere between 6 and 7 meters, curled back and forth within the abdominal cavity, where the colon is relatively short. Excuse me, relatively short at about 1.5 meters long. And then here's a picture of course, your small intestine there in the lighter pink, and then your large intestine or your colon in the darker brown. You've got the ascending colon, the transverse colon, the descending colon. The sigmoid colon is where stool is stored until it's released into the rectum and then out the anus. Waste, the remaining byproducts of food, known as feces, are your undigested food particles that travel through the descending colon, progress to the sigmoid colon, and then through the rectum to exit the anus. The liver is important in the GI tract because it helps maintain blood glucose. The liver stores sugar, and when additional sugar stores are needed during times of stress, the pancreas will release glucagon, and glucagon will cause the liver to release its sugar stores, causing the blood sugar to rise. The liver also detoxifies drugs and hormones and foreign substances, and that's an important concept because as we give medications to elder patients, if their liver functions aren't very well, then the medications that we give, particularly if they're taken daily, if they're not eliminated or detoxified by the liver, patients can become toxic on standard doses of medication. For that reason, we should consider reducing the adult dose in half in those patients in liver failure, and certainly those patients over the age of 70. The liver also produces plasma proteins. It aids in blood clotting. Bile is produced in the liver. It is stored in the gallbladder, and bile is necessary in the digestion of food. The gallbladder, as I mentioned, stores the bile, and the sphincter of Oddi is located at the end of the common bile duct, and it regulates the movement of the bile into the duodenum. Here's just a visual then of the liver, the gallbladder, and the stomach, and where they are in relationship to each other. And I think what you can note here too is the vasculature, the blood vessels that travel through the mesentery that help supply blood to those organs, as well as uptake nutrients when they're broken down. The pancreas is located in the mid-epigastric region. It's tucked underneath the stomach and points backwards towards the retroperitoneal space. It has endocrine functions. In other words, it is an endocrine gland. It does release insulin, which helps lower your blood sugar, and glucagon, which helps raise your blood sugar. It has exocrine functions as well. It secretes pancreatic fluid. The pancreatic duct expels these fluids at the junction of the duodenum along with bile. So pancreatic fluid and bile help break down and digest amino acids, proteins, and fats. Pancreatic failure, one of the indicators that a person may have pancreatic failure is a very foul-smelling stool containing a lot of undigested materials, because if pancreatic fluid is not being secreted into the mix, the food is not broken down and digested well. The peritoneum is a thin layer that covers most of the intra-abdominal structures. You have your parietal peritoneum, which covers the wall of the abdominal cavity, and you have your visceral peritoneum, which covers the organs. And the peritoneal cavity is the difference, is the space between the visceral peritoneum and the parietal peritoneum. The mesentery is a structure made up of arteries and veins and nerves that serve those organs. Visceral pain is activated by pain receptors enclosed within the cavity of the chest, the abdomen, and pelvis. Visceral sensory nerve fibers transmit with the autonomic nerves of the sympathetic and parasympathetic nervous system to communicate with the brain and spinal cord in the brain. Because of that, visceral pain is often described as dull or poorly localized in the midline. It's often described as a cramping, a burning, or a gnawing pain, and usually has to do with organs. So here are the pathways of visceral pain with the sympathetic nervous system in red and the parasympathetic nervous system in blue. So visceral pain can be relayed to both parasympathetic nerve fibers in the pelvis and the vagus nerve, to the sympathetic nervous fibers from the organs themselves. Somatic pain is activation of pain in receptors in the cutaneous tissue of the body's surface, or deep body tissue. Along with somatic pain comes referred pain, and referred pain is pain that's perceived as occurring in a part of the body other than the true source. So as an example, when a person is having a heart attack, the pain is actually in their chest, but it may radiate to the neck and the jaw and down the left arm because the nerves or the receptors within that tissue, the nerves within the tissue of the heart are also the same nerves that are within the tissue of the neck, the jaw, and the arms. And so that's why you may have that perception that there's pain in those areas when it really isn't. Okay? So here are different patterns of referred pain. Certainly with hiatal hernias, you can get pain in the shoulder, pain in the neck, cardiac disease, pain down the arm, the neck, the jaw. With cystic duct stones, pancreatic disease, esophageal hernias, you can get pain in that left shoulder. Gallbladder or common bile stone, you can get pain in the right shoulder. Gastric ulcers, you can get pain in the shoulders, between the back. Same things with gallbladder disease and hiatal hernia. With a perforated pelvic ulcer involving the pancreas, pain in the back. Duodenal ulcers, you can get pain in the small back or lower back, which could be the pancreas, gallbladder, the tail of the pancreas, gastric ulcers. So all those things could cause low back pain. Of course, the life-threatening one that would cause low back pain would be a dissecting thoracic aneurysm. The GI tract, there may be bleeding from the GI tract as a result of trauma or rupture of solid or hollow organs. We know that when solid organs rupture, they spill their contents into the abdomen, causing a peritonitis. And the hollow organs, when solid organs rupture, they bleed heavily into the abdominal cavity, causing a peritonitis. And when hollow organs rupture, they spill their contents into the abdominal cavity, causing a peritonitis as well. The fibrous capsules around the organs may bleed themselves because they have a blood supply, or the organs themselves will bleed. Sometimes, as an example, when we're thinking about that, you may rupture your spleen, but you don't rupture the capsule that the spleen is in. And as the spleen hemorrhages inside the capsule, it kind of tamponades itself. Otherwise, you might have some significant, serious, life-threatening bleeding. Inflammation is a result of infection, chemical irritation, toxins, autoimmune conditions like lupus. The source and location help determine the cause of the disorder. It's really important when assessing a patient with abdominal pain to get an adequate history and a good, thorough physical exam. Your history in abdominal complaints is going to be far more valuable than the physical exam. Your physical exam, if there's pain, is going to be limited to OPQRST and perhaps palpation, which tells you really nothing. But your history is where you're going to get an idea of what's going on inside that belly. The pain may be constant, or it may be intermittent or colicky. As part of your history and thorough physical exam, determine whether or not there's any nausea, vomiting, diarrhea, constipation, bleeding. Is there any family history of abdominal problems? Any past medical history, any social history concerning alcohol consumption, because certainly heavy alcohol consumption can lead to pancreatitis, cirrhosis of the liver, as well as ulcers and GI bleeding. Medication use, NSAIDs, notorious for causing GI bleeds, and keep your questions open-ended rather than answering close-ended questions, because we want them to describe their pain. That might help us know whether it's somatic or whether it's visceral. Certainly if it's visceral, then that could be an organ, where if it's somatic, that's typically deep within the tissue of the abdominal wall. So ask open-ended questions about their pain. Inspect the abdomen, looking for distension, bruising, swelling, scars, pulsatile masses, which would indicate perhaps a dissecting abdominal aortic aneurysm. And is there any discoloration around the belly button or around the flanks? We'll see bleeding or bruising around the flanks when there's pancreatitis. May also see with abdominal hemorrhage some bleeding around the bruising around the umbilicus. You want to listen to all four quadrants to make sure that they have bowel sounds. It's normal for us to have some gurglings and pings. Obviously, if it sounds like boiling water, then those are hyperactive bowel sounds. And we know that the GI tract is extremely active and irritated. If they're absent, you have no gurgles, pings, or anything at all the whole time that you listen, that certainly would indicate perhaps a bowel obstruction. Palpating, I'm just not a fan of palpating the abdomen, particularly in trauma. However, they do teach us to palpate the abdomen to determine the presence or the absence of tenderness, to see whether or not the patient's guarding. If I start to palpate and it hurts, they're going to tense their abdominal wall up. Is their abdomen rigid and board-like, which you see with peritonitis, which could be both hollow organ contents or blood? Do you feel any palpating masses, particularly in that lower right quadrant when we have a dissecting aortic aneurysm? Any swollen organs, like in the case of right heart failure, you can clearly palpate the liver, particularly if you sit them up at a 45-degree angle, and that would indicate that perhaps you got some right heart failure. And then rebound tenderness is just cruel and inhumane. Certainly would indicate peritonitis. Extremely painful. Doesn't change what you do. That's the thing about pushing on the abdomen and making them hurt more, is that if they tell you their abdomen hurts and they tell you where it hurts and describes it, that's probably good enough. You start pushing and prodding and you just make them hurt more, and it doesn't change your treatment. So here they are pressing one hand on top of the other, taking the top hand and pushing the bottom hand into the abdomen to palpate our four quadrants. Percussion. Percussion is an art, certainly something that some people do to determine whether the abdomen is full of air or full of fluid, just like when you percuss a chest. That requires you to lay 3 fingers on the abdomen and strike the second finger or the middle finger. As you strike that middle finger, if the sound is hyper-resonant, like a kettle drum, then the abdomen is full of air. If the sound is dull thud, then the abdomen is full of liquid. There's a variety of disease-specific findings that you can see, and perhaps in your lab with Ray, you can look at doing some of these types of exams, looking for Murphy's sign, which would indicate acute cholecystitis, rebound tenderness, which again I don't recommend at all. Rovig's sign you'll see with appendicitis, Psoas sign with appendicitis, obturator sign with appendicitis, cutaneous hyperthesia with neuropathy, and that's cutaneous hyperthesia is when you touch the abdomen and the abdomen is extremely hypertender with even the lightest touch, and that often can be the result of neuropathy from diabetes. Cullen sign you'll see with an ectopic pregnancy, that's the bruising around the abdomen. A Graves-Turner sign is the bruising on the flanks, which you'll see with pancreatitis, and Kerr's sign is bruising of the abdomen as well, which you'll see with pain, spleen, or cholecystitis. As you're doing your assessment, or as you complete your assessment of the abdomen, you've examined it, you've listened to it, you've inspected it, determine whether or not they have any immediate life threats. Are they bleeding inside the abdomen? You can bleed your entire contents and not spill a drop. And if they do have some sort of immediate life threat, manage it the way you've been taught, looking at your airway, excuse me, your breathing and your circulation. Excuse me again. Sorry about that. Abdominal pain is, it hurts. We've all had abdominal pain from time to time, and it can be severe. And there's no reason that we can't relieve abdominal pain. Old school folks will tell you, nope, absolutely nothing for abdominal pain, because they don't want to mask any symptoms. But the reality is that the sooner we start alleviating their pain, the better that they're going to feel, or the sooner that they're going to get better. So administering medications like nitroglycerin, morphine, administering medications like morphine, fentanyl to help relieve pain is important. And if there's a lot of nausea and retractable vomiting, then certainly some sort of antiemetic to help that. Transport them in the position of comfort, and that certainly could be rolled up in a fetal position on their left side, as we commonly see with appendicitis. Drawing their knees up regardless is beneficial, as it releases the tension on the abdominal wall. So if they have like a peritonitis and aren't feeling well, putting a pillow under their knees to help draw their knees up would be helpful. Abdominal wall hernias. Here's a good picture of an abdominal wall hernia. It's a protrusion of the abdominal contents through a defect or weakness in the abdominal wall. It's congenital. It certainly can be caused by the older we get, the greater chance we have of this hernia. Obesity increases the risk. Prior abdominal surgery weakens the wall of the abdomen, and therefore you could herniate. Surgical repair, screens put in, abdomen muscle tightened up a bit, and may prevent that from occurring. Many people have these, and some have them fixed and some don't unless they're extremely painful. The problem with the abdominal hernias is, as intestines or abdominal contents pouch out into that hernia, they can become twisted and end up with a decreased blood supply and can become necrotic, and patient can get gangrene and all kinds of nasty stuff. Incarcerated hernia, that's where the abdominal contents won't go back through the hernia. And there's where that leads to strangulation. That leads to necrosis of the abdominal small intestine or large intestine or whatever it is that's herniated through there. Signs and symptoms include pain and fever, nausea, vomiting, and then signs of bowel obstruction. Because certainly if a section of intestine is being strangulated, peristalsis stops and things are not allowed to move through the system. So just like plumbing, the more you put in, if it's not moving through the system, eventually it's going to back up and cause the nausea and the vomiting. Okay, don't attempt to push it back in. Provide supportive care, IVO2 monitor if necessary, and that is a surgical emergency and needs to be addressed. Now, esophagitis is any inflammation or infection of the esophagus. It can be caused by candidus. It can be caused by infection. It can be caused by caustic injection, esophageal reflux. It can be caused by esophageal rupture, and certainly aspirin can cause an inflammation of the esophagus over time as well. Higher incidence of esophagitis are seen in diabetics, those with HIV, those who are alcoholic, those with esophageal cancer, pregnancy just because there's an increase of GERD and a decrease in motility of the GI tract, and those on corticosteroids like prednisone. Esophagitis, there's a burning in the center of the thorax and it gets worse when you swallow. The history is important. Gradual onset, burning pain, center of the chest, gets worse when you swallow. You're going to look at the neck, the chest, the abdomen to see if you're dealing with an actual rupture of the esophagus versus an inflammation of the esophagus. And there's no specific treatment in the pre-hospital environment other than well, it's not pre-hospital. Treatment is to reverse the cause. You can have an esophageal ulceration where you develop ulcers in the esophagus, and those would certainly be painful. A person may have a hiatal hernia, which is a hernia just above the diaphragm, which causes a constriction and leads to the gastric reflux disease as well. Esophageal candidiasis, it may grow into the oropharynx, down into the esophagus. It's burning pain in the esophagus, pain on swallowing, dehydration, IV fluids, and candidus is a bacteria or some sort of pathogen. So good hand washing is encouraged of the patient so that they prevent the bacteria from getting into their esophagus while they eat or drink foods. It's also known as infectious esophagitis because it is a pathogen. The esophagus can bleed in severe cases, will cause nausea, vomiting, fever, chills. If left untreated, necrosis of the esophagus is a potential problem. They're going to have epigastric pain, so maybe perceived as chest pain, and they may have some difficulty in swallowing. So here's a severe case of Candida esophagitis, and while it's difficult because we're not gastroenterologist, when you look at this particular visual down a camera picture when they're doing a EGD, the walls of the esophagus are normally quite flat and nice and pink, and in this particular case they're swollen. Hard to tell. They look like billowy clouds, but there's quite a bit of swelling in that esophagus. Esophageal reflux disease, also known as GERD, gastric esophageal reflux disease. It's a result of a weakened lower esophageal sphincter. So stomach contents, particularly after a large meal, have a tendency to move backwards up into the esophagus, bringing with it very strong gastric acid, and over time causes an eroding of the esophagus. There'll be burning, irritation. GERD's seen more commonly in the obese, in smokers. Alcohol use will weaken the lower esophageal sphincter, leading to GERD. And GERD, like esophagitis, is a burning pain in the center of the chest. Caustic ingestion will also cause a burning of the esophagus. If you ingest a corrosive like a strong acid or a strong base, whether intentional or accidental, to include things like toilet bowl cleaners, oven cleaners, bleach, battery acids, these caustic substances will cause a coagulation necrosis of the esophagus, which limits penetration through the tissue. If there's a good thing, once that coagulation necrosis occurs, then those caustic agents have more difficult time penetrating deeper into the esophagus. Here's an example of necrosis, and of course coagulative necrosis is just necrotic tissue, and you can see the arrows are pointing to a darker color of tissue, and that's dead tissue as a result of not getting a good blood supply to that particular tissue. Alkali ingestion, acid ingestion would cause the coagulation. Acid ingestion would cause the coagulative necrosis, where alkali ingestion can cause liquefaction necrosis. It leads to full thickness esophageal burns, orofacial burns, drooling, vomiting, pain on swallowing, hoarseness or stridor, and chest pain. Liquefaction necrosis is just that, necrotic tissue that's sloppy and loose and liquidy because it's been destroyed by the strong alkali. With caustic ingestions, get a accurate history. Relay to the receiving hospital that they ingested a caustic substance. Try to identify and transport the container if you can. Note the time and the amount ingested, and whether or not they did any self-treatment. Late complications associated with caustic ingestion include tissue sloughing, scarring as the tissue heals, esophageal stricture formation where the esophagus becomes narrowed, and then gastric outlet obstruction. They may have drooling. We want to protect their airway. If they if their level of consciousness is altered to where they can't protect their own airway, we want to consider endotracheal intubation. If the caustic ingestion has caused severe swelling of the upper airway to the point where you're not going to be able to get them intubated, you need to consider a cricothyroidectomy. We don't induce vomiting in caustic ingestions, and often people will say, well, don't induce vomiting because it burned all the way going in, it's going to burn all the way coming out. And while there may be some truth to that, the biggest reason we don't induce vomiting is that anytime you make somebody throw up, particularly if their mental status is altered at all, you increase the risk of aspiration. And you just really wouldn't want to get that into their lungs at all. NG tube only under medical direct orders, because again, an NG tube, although not no longer in our scope of practice as a paramedic, an NG tube insertion increases the risk of aspiration. Borhave syndrome is a perforation of the esophagus after a forceful vomiting. You can see mortality rates of 50% without surgery in the first 24 hours. So it could be a severe life threat. Again, it's after forceful vomiting. We see this Borhave syndrome certainly in bulimics who purge. They're going to have diffuse pain in their chest that radiates to their neck and back and abdomen, difficulty breathing, swallowing. They may vomit blood. They may be cyanotic. Late causes, esophageal contents enter the mediastinum. So now you've got gastric acid around the heart and the lungs and the 8 great vessels. Subcutaneous emphysema is common in the neck if the esophagus is perforated. The patient may be tachycardic, tachypneic, have a rigid abdomen because of all the contents that are spilled in there, may develop a fever and be hypotensive as well. Treatment is early surgical intervention, so that would require us to recognize that the patient has a history of forceful vomiting and then develop these symptoms. So rapid transport, manage the airway, treat the hypoxia, and treat the shock. Esophageal foreign bodies, some may easily pass, larger ones may obstruct the airway or obstruct the esophagus. The esophagus normally narrows in 4 different places, and depending on the size of the object, it may get stuck in one of those places. It narrows at the junction of the esophagus with the throat, so where the throat and the esophagus join, there's a narrowing. There's a narrowing where the esophagus is crossed by the arch of the aorta, and a narrowing where the esophagus is compressed by the left main stem bronchus, and a narrowing of the esophagus at the esophageal hiatus, where the esophagus comes up through the diaphragm. Signs and symptoms of foreign body: acute onset of difficulty swallowing. They'll tell you they've got something stuck. They may not be able to swallow at all, leading to oral secretion, pooling, drooling, that sort of stuff. For foreign body obstruction, physical exam, if you can see it, probably not likely if it's stuck in their esophagus, unless it's in their upper airway. The pooling of oral secretions in the back of their mouth raises suspicion that they're unable to swallow. For foreign bodies, consider airway management, rapid transport. Glucagon is a smooth muscle relaxer as well, so it may help dilate the esophagus somewhat. Another certainly antidote that we see being used for meat and food stuck in the esophagus is a very highly concentrated meat tenderizer slurry, where you put meat tenderizer with water and have them drink it. Hiatal hernia, the stomach extends proximally upward through a weakness in the diaphragm, so you've got a bit of the stomach popping up through the diaphragm. Symptoms are very similar to GERD. Heartburn is very predominant. These patients may rupture their esophagus, so look for that as well. They're going to have abdominal pain. You should rule out cardiac as well, because with hiatal hernias, they're going to have a burning epigastric pain, which in some people could be heart. So here's just a view of different types of esophageal herniations, or hiatal hernias. Mallory-Weiss syndrome is a longitudinal tear in the distal esophagus proximal to the stomach. It's at the stomach level, at the gastroesophageal junction. It may involve some arterial bleeding into the esophagus and stomach, so there'd be some bright red blood. But a Mallory-Weiss tear there usually isn't a lot of bleeding. Just more of the same sort of signs and symptoms that you see with a perforated esophagus. They may be vomiting up bright red blood. Ask them about history of vomiting. Take them in the position of comfort. They may continue vomiting, so give them antiemetics would help, and IV fluids to replace the volume lost. Esophageal stenosis and stricture. A stenosis is an abnormal narrowing. Remembering that the esophagus narrows in 4 different locations, this would be an abnormal narrowing. Stricture, a specific form of narrowing, usually from scar tissue. They're going to have trouble swallowing their secretions, so they may again have issues with oral secretion. There's no pre-hospital treatment that we can do for this. IV fluid so that they don't have to drink liquid and get dehydrated. They're unable to swallow foods, liquids, and they should be transported into a position of comfort. Tracheoesophageal fistula, or TEF, the communication between the trachea and the esophagus exists. In other words, the esophagus grows into the trachea, and there's an opening between the trachea and the esophagus. It's mostly congenital. It's associated with esophageal atresia in where the esophagus is not continuous from the mouth to the stomach. It's a potentially fatal disease or a fatal condition because of respiratory complications. You can imagine that patients with TEF, if you swallow things, they hopefully will go into your stomach, but because there's an opening into your trachea below your vocal cords, you can dump that stuff right into your lungs. Symptoms in infants would be frothy white bubbles despite suctioning, rattly cough, choking, cyanosis, and it worsens during feeding because you're, putting stuff into the trachea and it's getting into the lungs. Symptoms in adult include fever, cough, chills, respiratory distress, frequent pulmonary infections. During transport them in a position that would reduce aspiration risk, suction them, keep their head up, give them an IV for hydration, and if they're having difficulty breathing and can't maintain SATs with oxygen and positive pressure ventilation, then you might have to do some endotracheal intubation. This would be in a case where they had a severe respiratory infection as a result of their TEF. So here's an example of esophageal atresia, where the esophagus does not go all the way to the stomach. And here there are two different cases where the esophagus coming down from the mouth becomes part of the trachea in the second picture, or the part of the esophagus above the stomach becomes part of the trachea. And the fourth picture where the esophagus from the mouth and the stomach become part of the trachea, and then the last picture showing that communion between the two, an opening between the two, allowing for air to go into the stomach, which isn't a big deal, but stomach contents to go into the trachea, which is a big deal. Esophageal varices are dilated veins that are enlarged from an increased pressure. It's the result of damage to the valves within the vein. We see esophageal varices not only from damage to the valves within the vein, but more related to venous pressure as a result of retrograde blood flow. Retrograde blood flow occurs in patients with liver failure or in patients with right heart failure. When the right heart fails, blood backs up into the portal vein, causing liver enlargement, but the veins for the esophagus come right off the portal vein. So if the portal vein becomes engorged, so do the veins of the esophagus. Okay. It's usually asymptomatic unless one of them ruptures, and then when they rupture, there's a significant amount of bleeding that could be life-threatening. Cirrhosis is the most common cause of esophageal varices. So because of that, the history might include alcoholism. They're not going to want to eat. They're going to feel nauseated and maybe vomiting. There may be weight loss. They may be jaundice as a result of a liver failure as well. If they have a sudden bright red blood accompanied by a significant blood loss, significant enough to cause shock, that's a good key of an esophageal varice that has ruptured. if the esophageal varices is bleeding internally, they're not coughing up, or they're not vomiting up bright red blood, it's just dumping into the stomach, then you're going to have signs of shock with no evidence of bleeding. So whenever you have signs of shock with no evidence of external hemorrhage, you have to think about internal hemorrhage. You have to think about things like an esophageal varice. You have to think about things like a thoracic aneurysm or an abdominal aneurysm. Again, if the esophageal varice ruptures, it can be life-threatening, so management is supportive. Correct hypoxia. Treat the hemorrhage with IV crystalloids, and again, if the pressure is 90 or better, we're going to practice permissive hypotension. Large bore IV lines, because they may need to be giving some blood when you get to the hospital. Cirrhosis is a chronic liver disease. It's the #1 cause of liver transplants in the United States. Tissue replacement by fibrotic scar tissue can cause cirrhosis, and eventually you end up with a progressive liver function is lost. The liver fails to function as it should. It's not able to detoxify your blood or filter out any medications that you take. Causes: alcoholic liver disease and hepatitis B, hepatitis C, those things. Signs and symptoms of cirrhosis is spider angiomata, and spider angiomata is distended veins in the face, on the nose, on the abdomen, as a result of blood backing up through the portal vein, causing blood to back up in all the venous system. Palmar erythema, Dupuytren's contracture, gynecomastia, testicular atrophy, ascites, all signs and symptoms of cirrhosis. Some other signs and symptoms, I don't know if that's caput medusa, which is a distension of the veins of the abdominal wall, Factor hepaticus, which is a very pungent breath odor, jaundice, asterixis, which is a lapping of outstretched dorsiflex hands, and encephalopathies. Hepatic encephalopathy, when the liver fails to function out the toxins. Those toxins, as they build up, particularly ammonia, can cause the brain not to function properly. So you get an encephalopathy. Esophageal varices, again, are common from cirrhosis as well. Cirrhosis affects your immune system, your coagulation cascade. It affects your kidneys, your central nervous system, formation of bone. Liver's pretty important. Do a physical head-to-toe exam. Look at that abdomen for signs of liver failure. Look at the whites of the eyes for signs of icterus and signs of the yellowing of the whites of the eyes, which is icterus, and jaundice on the other parts of the skin. Hepatorenal failure is the onset of kidney dysfunction in patients with liver disease, and this occurs when we have no identifiable reason for the kidneys to be involved. It's the result of decreased renal blood flow to the kidney. As a result, you get decreased urine output and a lot of increased leg swelling. Hepatorenal failure, you've got both the liver and the kidneys that aren't working properly, so you're going to be short of breath from fluid retention. You may have a history of GI bleeding, may have issues with your managing your ABCs. Mental status from encephalopathy could occur. Ascites, which is just a retention of fluid in the belly, and there really is no pre-hospital treatment for it. Here's an example of ascites, and you can see the spider angioma, the vessels on the abdominal wall that are distended and very visible in this person with cirrhosis. Acute hepatitis is inflammation of the liver, and that can be caused by hepatitis A. That's a lifelong immunity issue. You're going to have a lifelong problem. No, not with hepatitis A. I'm sorry, I'm thinking of hepatitis C. Hepatitis A you recover from that and you develop a lifelong immunity. Hepatitis A is usually contracted through eating tainted food. It's usually transmitted fecal-oral. So in food preparers who don't wash their hands after they go to the bathroom can transmit hepatitis A. In mothers and fathers who change their baby's diapers, again, handle fecal stuff, and don't wash their hands, they can get hepatitis A as well. But you do recover from it. There is a vaccine available as well. Hepatitis B, it's the number one cause of acute and chronic hepatitis. It's transmitted by infected body fluid. In the old days, certainly some of the prison tattoos where you just take a needle and dip it in ink and poke it into the skin to make a tattoo could lead to needle sharing, which led to hepatitis. Sexual contact can you get hepatitis B. Infected needles, an infected mother can pass it on to the child. Complications, you get hepatitis, inflammation of the liver. Leads to cirrhosis and eventually liver failure. Can lead to liver cancers. There is a vaccine that's available, and all healthcare workers, if there are no health reasons that you can't, should really consider getting the vaccine. Hepatitis C is transmitted through infected blood and body fluids. It leads to chronic hepatitis and cirrhosis. There is no vaccine available. That's not true. There is a vaccine available now. Just came out last fall. It's extremely expensive, requires multiple injections, but has been very effective in curing hepatitis C. Alcoholic hepatitis is caused by increased alcohol consumption. You end up with acute liver inflammation, leads to jaundice, liver failure, and carries a high mortality rate. Drugs and toxins can cause hepatitis as well. Halothane, which is a volatile anesthetic that's no longer used, could cause liver failure. INH and fentanyl, dilantin, mixing INH, which is vitamin B3, with dilantin, causes an increase in dilantin toxicity, which can lead to liver hepatitis. AZT, which is used to treat the HIV, the HIV virus. NSAIDs like naproxen sodium, ibuprofen, aspirin, certainly can cause liver failure as well as Tylenol. Hepatic tumors are prone to develop, your person who's had hepatitis is more prone to develop hepatic tumors, cancerous tumors. And the liver is a very common site for primary and metastatic cancers because it filters all the blood. And when cancer cells do get released into the bloodstream, from their origin site, they do have to be filtered through the liver, which makes it common for the liver to be the site of both primary and metastatic cancers. Signs and symptoms of a hepatic tumor include, looks like you got hepatitis. You've got pain, abdominal distension, either cirrhosis, liver failure signs and symptoms, cancer signs, extreme weight loss, nausea, that sort of thing. You want to treat any life-threatening conditions that the patient may have and provide supportive care. All right, so with that ends our part one of abdominal disorders, and I'll be talking to you soon about part two. Questions, you know how to get a hold of me.